it's recording somewhere.
It says recording.
All right, so we're going to do a quick talk on PPE and intubation. PPE at that. So the best thing for intubation is a purified air personal respirator with goggles, with an N95, with a gown, with gloves, and then questionable sheer boot cover. The only reason why it's a question for a sheer boot cover is because in the doffing errors and cross-contamination, that occurs more frequently when doffing off the shoe and boot covers. So having a shoe that is capable of being cleansed afterwards is more appropriate and probably safer. So here's a study that was done by Dr. Roberge out of Pennsylvania. He's actually one of the scientists at the national, at the NIOSH, basically, laboratories that set the standards for protective equipment. And so he wrote this article looking at the evaluation and rationale for both using an N95 and a PAPR at the same time. And here they've got a model of a mannequin where they basically took an N95 and literally glued it to the face of the mannequin. And the mannequin is a high fidelity simulation mannequin, so it can simulate different inspiratory rates as well as different inspiratory pressures. And so what they found, the N95 mask was kind of hard to get on there tightly, so they glued it onto the mannequin's face and then put the mannequin in a PAPR and then did a bunch of other testing to see what sort of exposures occur or could occur. And so the first issue is just some common nomenclature is looking at aerosol generating procedures. This is what's kind of reported in the literature about this and the way that it's categorized. So what they found was that it was observed in prior SARS outbreaks that any aerosol generating procedures had resulted in healthcare worker infections despite droplet precautions. So those patients were wearing the usual droplet PPE, including N95, plus gloves, face mask, goggles, and caps. And under aerosolize conditions, we're still getting infected. So I think it's a really important kind of lesson to learn up front before we initiate intubations. N95s, here's kind of the basics about them. Masks are designed first by their ability to resist oils, or they're designated that way. So N means there's no resistance to oil, R means resistance, and P means oil proof. So an N95 mask is a non-oil resistant mask. Generally the ones that you can find at like Home Depot will include those, but also the ones you find at Home Depot are the ones for painters, which will be the R95s, or for those that are doing other industrial work, they'll have P95s. The N, R, and P don't have an influence on whether or not it's protective for you as a healthcare worker. They just have a description of what their resistance is to oils. All right, and then the 95 refers to the minimum efficiency, of meaning that less than 5% passage of particles that are 0.3 microns at a rate of 85 liters per minute. So that's what the 95 means.
That's not very reassuring.
What's that?
That doesn't seem very reassuring.
Yeah, well, and then 99% means that there's less than 1% passage of those. So if you had an N99, it would be that. And if you had an N100, it's not 100%. It's less than 0.03%. So close, okay. You know. And then N95 has an assigned protection factor too. And this is kind of important to understand, is that when you start going through these designations, you need to understand like what you're actually, talking about. And so the protection factor here is 10, meaning that about 1/10 of the contaminant could be potentially inhaled through the device. So on one side of the border versus the other side of the border. So again, less than 5% passage of those small microns, and then from a protection factor, less than 1/10 of contaminant inhalation.
Got it. 85 liters a minute seems like a lot, though. Isn't?
It's not as much as you think, because when you sneeze, you inhale at a rate faster than 85 liters per minute.
Got it.
An inhalation movement is that. So this is why these standards are kind of created this way. The other aspect is that, you can see here with these protection factors, like why an N95 with goggles alone under an aerosolizing condition with a virus that potentially only takes 1 to 3 particles to infect you is, can result in a healthcare worker infection. So Now, a powered air purifying respirator, right? This is a helmet and or hood with a face mask. At a minimum, it has 170 liters per minute airflow, which prevents the entrainment of air into the mask, right? So you can't suck harder than that, even if you're sneezing. And in this case, it keeps a positive pressure flow around and out of the hood or helmet. It shrouds and therefore can provide greater dermal protection compared to a helmet when you're using a hood. And it has an assigned protection factor of 25, meaning so that only up to about 4% of exposure, as opposed to the protection factor of 10. And so in this paper, he discussed, some of the other risks about intubation. There's risks of inducing aerosols. That risk is inversely proportional to what your distance is to the patient. So if you're 2 meters away from the patient, the person who's right beside the patient has 8 times the exposure compared to someone who's 2 meters away. So that much more important to understand like why you need to be in the PAPR and the N95 because of the amount of exposure you have. In addition, there's increased aerosolization with suctioning, that's both pre and post, increased risks with the patient coughing, and obviously also with patient bagging. There are a whole bunch of other websites to look at. EM-Crit with Scott Weinkart has a pretty cool set of videos looking at different ways of setting up safer practices between disconnecting somebody to perform suction through an intubation in a COVID patient, using a number of methods of confirming with your RT, clamping the unit, and then going through a way of introducing the connector pieces to allow for suction to be performed and then come back off and reconnect. And so anyway, come to that later. But here are the different risks that are involved with intubation. So in combined PAPR and N95, he initially said, listen, there's a 4% risk with PAPR. There's a 90% reduction with an N95 that gives you about a less than 0.4% risk when you combine the two. But at this time, when he wrote this, there weren't any studies really looking at this. And so that, studies in actual workplace with negative pressure isolation, in addition to pre-medication, to reduce salivation and coughing would further reduce that risk. But this might be a consideration where we talk with our colleagues, both in anesthesia and critical care, about, do we pre-medicate with glycopyrrolate or something else to reduce secretions before we initiate our intubation, in addition to our usual RSI drugs. The potential concerns here of combining these two is that there's an increased breathing resistance with being an N95. There can be difficulty appreciating a poor seal of an N95 under the positive pressure of the PAPR, and that there's communication difficulties with this. Some people may experience claustrophobia with wearing this, and the doffing is more complex. So you need to have a really good buddy system with you, RT, and somebody, maybe even a third observer, to help be certain that you're doffing the equipment correctly and minimizing your risks. In addition, it's going to be how do you clean these for reuse, since we're going to be in extended use and reuse scenarios.
Do you think there should be some decision-making as to when you put on the PAPR? Sounds like to me, if you've been wearing your N95, like we're doing, half the shift, and then it's time to intubate, and you put the PAPR on top, there potentially are some virus on top of the outside of your N95. Are you at risk for dislodging them with that turbulent airflow?
Yeah, I think that, so I don't know. It's a possibility. You are in the N95 that whole time too. So yeah, it'd probably be better to be in a new N95. Like when you look at all the scenarios, when they show you how to do all of this, right? Like 3M makes most of this, right? So when you look at how they teach people to do this, they don't teach people to use an N95 all day long.
Right.
They're not in extended use, reuse patterns. So, the N95 and under these traditional scenarios is a single use and dispose unit.
That being said, when I put on the N95 and the PAPR, it's not uncommon for that PAPR to dislodge your N95. So it's difficult to keep that good seal on the N95 unless you're really careful with the PAPR.
Yeah. So it's, you know, certainly this is something I would suggest that the best way to do this is to first do this in a simulation lab and run through the mechanisms and getting familiar with like how you're going to personally don and off these, because you know, the PAPRs are basically coming as a one size fits all, and the N95s are one or two sizes fit all.
Mm-hmm.
So in either case, and it depends on which N95 we're talking about as well in terms of its shape, whether it's the duckbill N95 or if this is the teal colored one. There's white ones, there's all sorts of different types of N95 shapes. And so, you know, the smartest thing to do, like from an infection control standpoint and from a like operational safety standpoint, would be for each person to go through a simulation test of like working through the mechanics of doing this, and then having checklists. Have a checklist of putting on your stuff correctly and a checklist of having somebody watch you take it off correctly. Those two, I like really can't imagine those things being diminished in any way. Like it should be the way we're doing it, and it should be really simple. Like outside each room that we're going to be intubating, there should be like a posted checklist of like, you did this, 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 and this before you walked into the room.
Sounds like what you're saying is, from a practical standpoint, a good thing to practice at the beginning of your shift.
Yeah, but also, right. But I'm also looking like, I think, you know, per depart, like wherever you're practicing. So outside of our hospital, even if someone else is watching this, that you have somebody try to do a human factors review of how you and your team are doing this together, because you're going to hopefully go in with a smaller team for intubation, whether it's just you alone or you with RT. Some groups are still including RT, nursing, and the doc in the room for the intubations. I don't know how necessary that is to have the nurse in there to push medication. Like they can just give you the meds and you can walk in and push the meds yourself during the actual intubation exercise. You know, obviously they're going to be setting lines and doing other things before that, and there'll be a need for them to be in protective equipment just the same. But I think having the less, you know, fewer people in the room during the actual aerosolize procedure is best. So anyway, so it goes through this whole long thing about how healthcare workers can be infected with severe respiratory pathogens, and they've got every right to be concerned about their own safety. We see this, you know, in our colleagues in crisis situations such as a SARS outbreak, where there's failure to undertake precautions. It can be disastrous. It can affect not only just the amount of healthcare workers that are available, but the actual confidence that they have in the system, the amount of sick calls that may occur as a result of just being anxious and not wanting to show up to work because I'm not feeling protected. And so really felt that, you know, when it comes down to this, the choice of appropriate PE should be based on solid science, not on fears. And at this time that he was writing this, there really wasn't a lot of science about the combination of N95 and a PAPR. And there was potential risks because of the doffing problems and some of the other issues that we just mentioned. So this was then followed by a study by his brother. And so that he and his brother and other colleagues then did a study of looking at the combination. So here's the scientific evidence that was then followed up with this, right? So in this study, they used 3 different types of N95 masks. They used the 1860, which is what we have at Palomar. They used an 1870 and this AO Safety, which is just a different company that makes this other N95 mask. And so they ran this in 2 different ways. The mannequin was set to take in 25 liters per minute to simulate kind of just light exertion, just being in the room, and at 40 liters per minute to simulate actually kind of, you know, doing a procedure and perhaps being somewhat anxious and taking in a little, you know, stronger breaths. And so those are kind of the 2. And so then they divided this into those two different groups. And then it was N95 alone, PAPR alone, PAPR plus N95 as the measures. And they looked here to see what was the protection factors associated with these. And so in a function N95 with it glued to the face of the mannequin, its protection factor was way higher than what was suggested before. So its protection factor was 107. The PAPR alone, so this was loose fitting PAPR, it's not glued to the mannequin. Protection factor was 35,000. The combined effect was multiplicative. It was 255,000. And that's at 25 liters per minute. At 40 liters per minute, it's about the same protection, about 214,000. When you look at the different styles, so the 1870 more or less had the same type of protection factor, except under 40 liters per minute, it was actually even more protective with that style. And with the AO safety group, similar protection factors were seen to the 1860. So the 1860 is pretty decent. Obviously, with 255,000 protection factor, those are good numbers. But you know, if you had to choose one out of that scenario, it looks like the AO safety was maybe even a little bit better. I don't know if it fits any better because I have no experience with it. But so then they looked at this in a different way, and they said, okay, well, what happens when your PAPR fails? Like, what do you do? What do you get? So with a deactivated PAPR at 25 liters per minute, its protection factor drops all the way down to 4. So way less protective when the battery runs out. And so this is, in my opinion, the most important reason why to combine the two. Because when you look at a deactivated PAPR while still wearing an N95, a protection factor is still over 2,000 and close to 2,000 when over 40 liters per minute. So again, a deactivated PAPR is really not that safe, and you're better to be in an N95. And since you can't predict if your battery is going to run out or not, or the complicated thing it would take for you to go in knowing that you had fresh batteries, like it's just not, like, just wear them both. Like that's pretty much I think the bottom line from this study. So this was just looking at, again, by the manufacturers, looking at those that were PAPR only. You can see how much lower the protection factor is than when you add the N95 to it. And that's seen across every manufacturer there. So any questions about that study? Cool. So this next one was an opinion piece looking at to PAPR or not to PAPR. It's a really insightful piece. It's worthwhile to read and has a lot more insight than what I'm sharing with you. But this is, we've covered a lot of that already in the previous two articles. So here, I think the important part is looking at and being very explicit about your donning and doffing, and understand the correct sequence of donning, and putting on your material first. In this case, this scenario is written for a Ebola virus exposure, so it was shoe cover first, then gown, then N95 mask and or PAPR. It was secured with face shield or loose fitting hood with the inner shroud tucked inside the gown. And so I think, that's important to understand, like, well, where does the shroud go? Does it go tucked on the outside? Does it lay on the outside? Does it lay on the inside? Anyway, here it was with the inner shroud tucked inside the gown, so the outer shroud would be outlying. And then hand hygiene, long cuff gloves to go over the sleeves of the gown. And then the doffing procedure should be performed at least 2 meters away from the patient. So again, that inverse proportional exposure is cubed, right? So the shoe covers, gloves, and gowns should be removed inside the room. And then a trained assistant should be available to help you remove and clean the PAPR. So this is where I think having a third person who's outside the room to help us clean our PAPRs is really important. The hood or face shield and N95 mask should only be removed outside the patient's room and then placed in a biohazard bag. And then all PPE should be removed so it's not to contaminate. And this is where in the previous studies they said, well, the biggest risk here is actually taking off the shoe covers. So again, perhaps wearing a shoe that's closed and can be cleansed and wiped down would be better. Hand hygiene should be performed after all the PPE is removed again. And the advantage of using a N95 mask for these aerosolized generating procedures is that it's disposable and doesn't have to be placed in this additional personal risk. except in the setting where we are, where now we're running out of N90, running low on N95s, I should say, and are having to consider reuse policies.
So interesting. I received an email from a friend regarding the stability of coronavirus, the SARS-2, and on porous fabric, it seemed like it only can last a few hours. So it makes you wonder whether wearing something that's a little less porous, like those shoe covers, and then taking them on and off, since it's just going to stick to your shoe and degrade over 3 or 4 hours. I wonder if that's going to change what we do in the near future compared to like this one done when you're looking at the Ebola, which might have been a little more stable on fabric and clothing.
Yeah, I don't know. I mean, it's hard to say. I mean, there are those recent studies looking at its stability on different surfaces, and on paper products, or at least on cardboard, it's 24 hours.
Yeah.
On porous fabric, it may be. I don't know it may be less. There may be.
I want to say it was about 3 hours on porous fabric. I'm gonna have to look at this. I just received this data, but it was interesting. When we're going home, you have to realize that unless you have a 3-hour drive home, that's still on your shoes and your clothing.
Yeah, you got to wipe your stuff down before, So that will bring up an important point too later of like traffic control bundling and what's a safe ingress and what's a safe egress from work, and being like having something in place for that. So this kind of led to some other stuff. I know I'm going to take crap for this, like literally at work. But whatever, I'm fine. All right, so lifting the lid on toilet plume aerosol. So, so essentially this was a look at like, is this a risk factor? Like, could this be a risk and a problem with contamination and exposures to either healthcare workers or to other patients? And so they asked the question, do flush toilets produce potential infectious aerosols? And then does toilet plume pose a risk for the spread of infectious disease? And so the most significant toilet plume, so in this article they go through and they say, well, one of the most significant toilet plume airborne infection risks are likely to be due to viruses. And perhaps the most significant of these is norovirus. Now this is an article, I think it was written back in 2004. So anyway, so they're like, okay, norovirus accounts for 95% of non-bacterial gastroenteritis outbreaks and about half of all the gastro outbreaks worldwide. It also can be transmitted in aerosol and has a low infectious dose, and it's shed both before and after. And so the scientists were showing, yes, listen, this is a real thing. It is a concern. When you go through the article a little bit more, they then bring up another important viral pathogen is the SARS coronavirus, which is known to shed in both feces and vomit. And a number of studies have suggested that it can be spread by airborne route. And then they go on to talk about H1N1, that it's been a demonstrated important epidemiologic feature of airborne transmission via toilet plume, has a potential for that. And that seasonal influenza doesn't normally present with diarrhea or vomiting, but it has in the past with different forms. And then in another part, they get into this part looking at the study by Marks and others where they studied restaurant diners who developed acute gastroenteritis following non-projectile vomiting, and saw that the position that you were relative to the source indicated your risk for also catching it. So 91% of the people at the table caught the infection, 71%, and then 56% at 2 adjacent tables respectively caught the infection, and then there were lower rates farther away. So it shows that an airborne norovirus transmission via vomit aerosol is possible as well. So the vomiting patient and diarrhea patient, and not even diarrhea, there's a defecating patient with a toilet plume can aerosolize. And then they further get into this idea of epidemiological and experimental modeling studies of SARS, indicating this is the most compelling indicator for the potential for toilet plume to cause an airborne
all right, so hold on one second. So basically what you're saying is don't ever use the patient bathrooms ever again.
Yeah.
Yeah, pretty much. Because if you're telling me there's plume, anytime you flush, it's going to be aerosolized and it lasts in the air for up to 3 hours, I can never use one of those bathrooms.
Yeah.
Okay. Good to know.
Did you use them before?
Yeah, and so, well,
Yeah,
you know, when you only pee,
right.
and so the second thing you're saying is don't flush.
No. I'm not saying, I'm not saying that. But
I'm not flushing.
we'll get into this. This is important, right?
Hey,
So
as Terry London once told me,
this is where, like, up to this point, you can just be like,
let
he's
it go.
paranoid and whatever else. Like, you can totally dismiss me. Anybody that lived with me in the fraternity house when I was, going through college knew, like, I was not the germaphobe. Like, if anything, like, I was the source. Anyway, so
I'm not using the patient bathrooms in the ER ever again.
no, you shouldn't.
And if it's yellow, let it mellow.
Right. So here, a report on the 2003 SARS outbreak in Hong Kong at the Amoy Gardens apartment complex concluded that exposure and disease propagation was likely due to virus-laden aerosols originating in the sanitary system. And the system was contaminated with SARS-CoV when the index patient was suffering from diarrhea, visited one of the apartments, and used the toilet. The sewer drain bioaerosol was believed to be drawn through dry floor drain U-tube traps into the bathrooms of the other adjacent apartments and through exhaust fans, and some of them had been exhausted, to the outside of the multi-story building, then carried upward to other apartments, and then prevailing winds were thought to be responsible for carrying the infectious aerosol to nearby buildings where cases also occurred. You muted yourself, Stephen. I can't hear you.
I'm curious, since this is also the typical similar coronavirus family that has a predilection for the lower respiratory tract, I'm curious to see what the infection rate is going to be with the SARS-CoV-2, and what's the inoculation needed to get infected, which we'll be really curious to see as well.
Right. And this is Hong Kong. This isn't like in the middle of nowhere. So obviously this was an apartment complex that had like a serious sewage problem and its sewage drainage problem, but it also indicates like where the risks are when you think about this on a worldwide basis of where sewage removal and sanitation are huge public health concerns already. The sanitation issues are concerning. So this, like, with all jokes aside, like, this is a real worldwide problem with this particular pandemic. And so anyway, so because the infectious waste and feces or vomit is mostly concentrated in the toilet bowl, carried upward to other upper apartments, and the prevailing winds were thought to carry this, the study suggests that SARS-CoV droplet nuclei bioaerosols produced from contaminated sewage may have a highly infectious and maybe so for significant periods over longer distances. So because the infectious waste is mostly concentrated in the toilet bowl, it might be reasonable to expect that infectious SARS-CoV droplet nuclei would also be produced during toilet flushing, but there haven't been to be.
It's a big jump to go from that. I mean, I'm sure it's possible, but this was also occurring in an area where it was epidemic. So who knows? There's so many confounding variables. But take-home message: stay away from toilet.
Take-home message is it's possible.
It's possible. Stay away from
proof that it's been transmitted that way by in that way, but it's certainly something that's possible.
Yeah, and it seems like if you were in a restaurant or a pub and you're using bathrooms, you're basically getting hot box with virus every time you use the toilet.
Yeah, there you go.
There you go. So that's a good.
This is one where what you might think is a courteous flush is not so courteous to someone else in the room.
I can see why you would want to avoid, you continue social distancing, especially when it comes to using these small restrooms in pubs and restaurants.
Right. So their summary conclusion was that contaminated toilets have been clearly shown to produce large droplet and droplet nuclei bioaerosols during flushing. So as much crap as I'm going to take for this at work, just put a lid on it. Like, that should be the learning lesson. Put the lid down and hide it, and then flush.
Our toilets don't have lids in the hospital.
Don't the ones in the employee have lids?
I don't think so. I don't remember seeing them in the call room nor in the patient rooms. They have, remember the old style ones had that little arm that would come down and you could, rinse out basins. I imagine that if you had that going at the same time, that would aerosolize it even more. So, yeah. All right, so don't flush.
Well, okay. Go at home, I suppose, then is a lesson. I don't know. Like, I mean,
The good
really,
thing I'm
like,
wearing my N95 the whole shift and I'm not eating or drinking. It really has cut down on my use of the bathroom.
apparently you're wearing your N95 while you're going to the bathroom too now.
Yes, I am.
Great.
Although I haven't had to go to the bathroom as much since we're not eating or drinking during our shift.
Right. While rocking in a chair in a corner. Anyway, so here's this. Let's get back to the PAPR stuff. Like, how do you clean these, right? So there's a technical data bulletin. You could just look this up and Google it and just type this in. And you'll get this, like, these questions like, do I need to fully disassemble the PAPR to clean and disinfect after each use? And they go through what their kind of guidelines are for that. At the end of the day, there's three main features to doing this. You clean it, you disinfect it, and you rinse it. But you don't submerge it. That's important to understand. So just putting a single bleach wipe is not enough. So it should be a three-part process. You first use a warm water, not hotter than 120 degrees, and gently brush it clean. Then disinfect it with a chlorine solution that's really light chlorine, 0.5%. And then gently rinse off that chlorine from the material, and then move. And that's the way of cleaning any of these devices. So
but hopefully, I think
same.
what you're saying is looking at this, like there's this long process where you wash, then you dry, then you rinse, and all this stuff. But if you had a low risk procedure where there wasn't a lot of aerosolized materials and you're pretty careful, just wiping it down might be enough. Looking at the previous page that you had up there, that first paragraph. Is that right?
Yeah. So this first paragraph was like, listen, hey, if this is a fair, if this is,
you're not blowing snot everywhere. There's no actual particles that you can
you're
see.
walking in and out of the room with the patient, you're taking care of that patient,
Just wipe it down.
fine, right? But if you're intubating the patient, that's not the key. Like, there's no small amount of particles.
Got it.
I'll show you data in a moment. And
All
so
right.
when you are, after you've done an aerosolized procedure, here's like how to clean the hood, how to disinfect the hood, and how to rinse the hood. And it's more or less the same thing I just explained previously. So you're just wiping it down. You don't soak the hoods in during cleaning. And there's a if you Google this for the VersaFlow cleaner, there's an actual video of watching them, and it makes sense. The way they clean it is they just use 3 different spray bottles. They use a rinsing, a cleaning rinse first, a disinfectant with an aerosolized chlorine, and then a rinse again with water, and then you're done.
So the bleach wipes would be enough, and then the only step we have is I guess we could use some other type of wipe, maybe the purple can wipe to do the first and third step, and then the bleach wipe for step 2. Is that what you think would be reasonable?
That would be reasonable. It'd be better to have like the spray bottles and actually aerosolize the top of it and clean it a little bit better through the aerosol, but I think it'd be a little more efficient.
I wonder if there'd be some benefit to teaming up. If you and another person are both wearing a PAPR, you could wipe while they're wearing it. You could do the steps 1, 2, and 3 while they're wearing it, and then have them take it off, and they could do it for you.
Yeah, or have a squirt gun fight with it.
There you go. Just don't flush.
All right, I'll put a lid on it. All right, so then possible SARS coronavirus during CPR. This is an important one to give consideration to. They looked at the case where there was a ICU nurse during chest compressions who had an indeterminate SARS testing, and there was another ICU nurse who was putting in an IV in the foot, giving medications and applying EKG leads, and he or she tested positive for SARS during this case. The others were asymptomatic, but all of them were wearing PPE, and they were all wearing gowns ×2, gloves ×2, safety glasses, face shields, shoe covers, hair covers, and N95 respirators. So it's important to understand that whatever you thought was an aerosolized generating procedure, what the risks were, just whatever you thought that level was, it needs to be higher. And you don't need to be paranoid, but you just need to appreciate that this is something you weren't thinking about before.
I don't know. I think this is like the money slide for me. So this is where we're going to have to make some really difficult decisions, because you're telling me nurses were wearing an N95, covered, shoe covers, face covers, safety glasses, gloves, and gown,
Two
ear
gowns.
cover, right? And they still became positive when they were far away because of CPR. So the question is for me, how futile or how efficacious is CPR in someone that's undergoing cardiac arrest from SARS, and is it something that should be done?
Yeah, so those are questions that are far more difficult and ethical to address. I'll say this from the emergency standpoint: we don't know if somebody has confirmed COVID when they come in cardiac arrest. So
But if you're in the ICU,
for us, it's a moot point, right?
But if you're in the ICU and
If you're in the ICU and you have a confirmed case, we know that the survival rate for the intubated patients is 50% for those that are older. So if you're intubated and older with COVID, it's a 50% survival rate, which is actually pretty good when you consider how bad this is.
Yeah.
But it's still a grim number, but it's a 50-50 chance.
It's really age dependent too, right? So if you tell me there's a 90-year-old
intubated. But if you look at this across the board with any patient who's septic and in cardiac arrest, I'll tell you the chances of survival are extremely low.
Right, and so that's where you start saying
you're looking at survival risks of less than 2%.
Right, and so
with that scenario of septic shock, cardiac arrest, right. So the overall, this is the one where any person who already isn't enthusiastic about CPR could easily be right 98% of the time by saying we shouldn't do anything.
And I think this is where you have to have that discussion early as a team when patients are in that position and they're about, perimortem or about to code, and have that decision and thought process done prior. I think that's an important thing. You're right. You got to differentiate CPR, but in the ICU, if you're potentially telling me, SARS had a 10% mortality rate. So if you had 5 people on that team and you had 2 CPRs, there's potentially one person gets it, and it could be really bad.
Yeah. And I think that this is, also the ethics of this vary based on the resource environment you're in. If you're in a resource rich environment versus resource poor environment, but at the same time, it's an issue of healthcare worker safety. So there's a lot involved here. I think that, this goes to show, again, if you're doing an aerosolized procedure, be in a PAPR and an N95 during this.
Yeah, I would almost say that you cannot do CPR in that scenario without it.
Right. I think that would be the best way of doing this. So if you're going to be prepared to do CPR, be prepared to do it that way.
Yeah.
And that brings up this issue of having a traffic control bundling, of looking at hospitals that prepared themselves for how they were going to safely ingress their staff and egress their staff, in addition to how they were moving the patients through the hospital. And those little arrows that you see here, and these blue arrows, really indicate a number of different things that are important. One is having having a spot between each transition where you're stopping to do hand disinfection. Like the fomite transmission for this is still the most important aspect. And while we're talking about masks, I don't want to miss out on the bigger picture, which is the fomite issues. So having explicit moments where you wash your hands as you transition from entering the hospital. So before you enter the hospital, wash your hands. Come into the hospital, as you're walking to your department, before you enter your department, wash your hands. Come into your department, put on your PPE. Before you go out to see a patient, wash your hands. And then once you go in to transition to seeing patients, you're washing your hands in and out of the room each time.
Which, when I read this study, I thought number one, the study was done during a resource-rich time. So this was in an isolated area. They had a lot of PPE available. And so all those red arrows were where they were donning and doffing as well.
Right.
So they were donning and doffing, putting on new PPE.
Well, no, they were only donning and doffing. The red arrows isn't where they were donning and doffing. They donned prior to walking into a patient zone. Mm-hmm. Right. So this I think an important part that I think we could do better at our own hospital is that before we ingress into the patient care areas, that we're already having PPE on before you ingress. And the fact that we're having it, like you've got to walk into the charge nurse station to get it, is not ideal.
Yeah, it should be really at entrance. And so this was a great study. I really like this because it was pretty simple and just really said, all right, let's just be really vigilant. And it
Right.
decreased the healthcare worker infection rate significantly, right? I think out of the 15 hospitals, only 2 happened.
I've got the data, I'll show you in a second. But the other aspect of this also was being explicit with where patients moved, and that you had patients transported to upstairs, not along common corridors where staff was entering and exiting for the hospital shifts. So you created specific mapping for that. And so I think that's also an important aspect, that each hospital, even within a system like ours, it's got 2 hospitals, that each unique layout has a specific plan for what's the traffic patterns for your patients and what's the traffic patterns for your staff, and try to mitigate that as best as you can. And so in this study, this was during a SARS outbreak in Taiwan. In the 18 hospitals that implemented this bundling, 0 healthcare workers were infected and only 2 patients developed nosocomial SARS infections. And by contrast, in the 33 control hospitals, there were 115 healthcare worker infections and 203 patients developed SARS.
Crazy.
So that, if that doesn't convince you, I don't know what would, and it should. And then, okay, so then we look at these things that are coming out here where people are showing like these different boxes. You mentioned about being hot boxed earlier. Putting a box over the patient to like hood them when you're going to go intubate them. And I'm going to show something first of like my own concern with that. But just to give a shout out to this guy here at the University of Cincinnati doing his master's thesis, this guy, Santosh Dunji, spent his whole thesis looking at this type of work in 2014. It's really cool. And I'm going to show it to you all in just a moment. I'm going to go through and just first think about these hoods and show you why, like, just putting a plexiglass hood over somebody doesn't work all that well. It's not going to decrease an infectious dose risk to you, right? And so here's a picture of a shower and a shower door. You can imagine the shower door is the hood. These are droplets. Droplets they don't quite move like Brownian motion. There's a slightly different swirl pattern that they have, but nonetheless, they move away from barriers. And so you can see that while the glass on the shower fogs up first, so does the mirror. And so droplets are getting everywhere, even if you can't see them. And I know that's, it should just be recognized. Like, you can't just put a barrier there and think the barrier is protecting you from an infectious dose.
My concern too is when you start doing these barrier methods and they're very visible, it does kind of give you this false sense of security that, oh, good, that's one extra step. And really, it really is a false sense of security.
Right. And you are like, listen, like that shower door works, like nobody's getting wet on the other side of the shower door. So there is a protective factor to it, but you are getting aerosolized just the same.
So there might be some benefit in the coughing patient as far as those hard droplets, but I can't see how really you still have to do what we're doing.
So it's more than just the barrier, and this is what we'll get to. So here, a ventilated headboard is a barrier with a hood filter, with supporting structures, plastic sheets, and then with a canopy, and then most importantly, that there's a duct, and it's a ventilated
negative pressure. That's negative pressure.
Right. So it's important to note that, so you attach a HEPA filter to it. This is why the HEPA filters are so important to any mechanism that you're using, right? Your PAPR has a HEPA filter on it, and your ventilated headboard should have one too. So you need to have a filter on it, and it doesn't filter out gases and odor molecules. So in order to filter volatile molecules, you need something else. You need to add a carbon filter to do that. So flatulence, for instance, is still recognizable even with all these hoods in place. Which
you're telling me if this was an aerosolized virus particle, it's probably not going to really filter it too much because they're too small and they're going to go right through the HEPA filter.
So, well, no, so the HEPA filters will pick up the virus particles. That's what they're designed to do. This schematic shows you what the HEPA filter discharge looks like. This is clean air that's being discharged and exhausted throughout the room, and kind of what the flow patterns are. Here you kind of see the eddies that develop near the vents in the room. And then he goes through and shows a comparison of cough dispersal in 4 different configurations. And the first configuration is showed here. This is a patient's in inclined position, coughs normal to the mouth at an angle of about 60 degrees to the horizontal. And this is a time study. So on the left side, it starts at 0.4 seconds and then goes all the way through down to the right bottom quarter of 20 seconds. And they simulate having a healthcare worker standing next to the patient, and you can see that within 10 seconds, the healthcare worker is taking a face load of aerosol. So you can't run out of a room quick enough and protect yourself from this happening. You need to be in your PPE before you walk into a room, right? Like, that's pretty common sense, but this shows what that dispersal pattern is like and how much the healthcare worker takes it when there's no barriers. There's 7,000 droplets that remain in the air at the conclusion of the study. You can see how the droplets are dispersed throughout the room. Then they use an operating hood with a HEPA filter on, and this significantly reduces the virus exposure, or droplet exposure, I should say, from 7,000 down to 2,500 droplets. Right? It doesn't eliminate the risk, but it significantly drops it down over time, and you can see that the headspace around the healthcare worker is far less involved in this, and so it's a significant reduction. So as much as I first showed you the picture of the bathroom and the mirror, having a negative pressure HEPA filter on a hood is beneficial, but you need to know what works and what doesn't. So the hood itself isn't sufficient in and of itself, just like the bathroom door isn't. The negative pressure HEPA filter.
Did they ever compare it to just wearing a standard surgical mask for the patient?
No, they didn't. This is just showing the cough.
That's been an interesting comparison.
So here, the abstract. This was actually a really well-written abstract that summarized the article really well, and basically said that the healthcare workers found to be exposed to virus droplets at a significant rate when if the filter's not on and working. But when it is on and working and appropriately deployed, it eliminated 99% of virus concentration within 25 seconds. So, and wasn't allowing droplets to come out of the hood when it was done well. So if you have a ventilating hood that's done well and you're wearing your additional stuff, that is protective. And so, but it can't just be just a box. It's not just a box going over them. And then, when you're in a PAPR, it's hard to put a stethoscope on. So I bought this. It's an echo stethoscope. I attached it to my existing stethoscope. And this is on the right side. You can see it's picking up both the heartbeats and the breath sounds. And so it can display it to you, but with an earpiece, you can just basically Bluetooth this to an earpiece and just put it in one of your ears. So that way you've got one ear open for ambient sounds and communication with your staff, and the other ear, you can just focus in on that when you're listening for heart sounds and breath sounds and making your assessments. You can also record this, but you can also reduce the number of providers that have to make those assessments. You can share assessments with your critical care colleagues, with nursing and so on and so forth. So this way, this doesn't have to be done. And you just wipe it down, clean it, or put it in a bag and dispose the bag and use it use it that way. There's a couple of different ways.
I hate to say it, but I wonder if we're getting to a point now where the risk of getting infected with someone actively coughing, and so minimizing your time with face-to-face patient care, minimizing your physical exam, and starting to rely a little bit more on your ancillary data.
Yeah. So I thought about that too, right? And yesterday I almost made a mistake on a 10-year-old. I had a 10-year-old autistic kid who's both he and his mom are coming in for evaluation. And from all intents and purposes, looking at him, you know, it didn't look like there was not much of a problem. And I was like, okay, I'll just swab you guys and send you guys on your way. And before I did that, I was like, let me just break this out and take a listen here to both of you before we do this. And this kid was like inspiratory, expiratory wheezing, right? And suddenly, like, there was an airway, like he was having bronchospasm. And I wasn't going to pick that up on a chest x-ray. And I wasn't going to pick, right, unless it was like severe, right? But otherwise, you're going to miss out on chest x-ray. You're going to, like, so there, like, there's still a place and role to be a doctor and like do good medicine.
Absolutely.
Like, right? So I think like we have, if you have a technological opportunity to overcome a deficiency, that you're almost obligated to do it.
And how much did you pay for your little device?
Like, listen, I don't have stocks in this or any connection to this, but
How much you paid for that?
This was $200.
All right.
So, you know, if that, you know, if that's a possibility, then great. If not, then there's other ways of doing that. You can use an ultrasound to show lung sliding. You can, you know, do a couple of different things, but obviously, again, you're going to, with lung sliding, that's beneficial to the person that you just intubated, showing that you've got equal sliding on both sides and you haven't main stent somebody until the chest x-ray is done. But I mean, pulse ox wave, you know, end-tidal CO2, capnography wave, those are sufficient to show you like you're in the airway. But more importantly, that's really only necessary for people that aren't using video laryngoscopy. If we're doing video laryngoscopy, like, I could care less about any of that because I've got the tube. I've seen myself put the tube in between the cords and put the balloon up and the balloon secured and so on and so forth. So, and then I think the only other thing worth mentioning is this idea about, you know, look at some other videos of how other people are setting up their intubations and performing their intubations and minimizing bagging beforehand and then getting connected, you know, directly to a ventilator rather than bagging directly after. Like, just close the circuit as quickly as you can and do that. Cool. Any questions? Any additional comments? You're muted, by the way, dude. You gotta unmute
Stay
again.
out of the bathroom. Take home message. Stay out of the bathroom. Wear a PAPR and an N95.
Yeah. So yeah, put the lid down, flush, put a PAPR and N95 on, and be really meticulous about the way that you're doing this and practice this with your team before you do it so that you're not making it up on the fly.
Yeah, be safe.
All right.
Thanks, buddy, for putting this together.
Thanks.